Good morning, good evening, everybody, wherever you are. And thank you very much for joining us for this ADI, HelpAge International and WHPCA webinar on dementia care and palliative care during and beyond the COVID-19 period. It is a pleasure to welcome you to the webinar. I am Paola Barbarino, and I'm the Chief Executive Officer of Alzheimer's Disease International. Next slide, please, Annie. And the next slide, please. Today we have a very packed agenda, and if you have been to one of the ADI webinars before, we will go through it quite quickly, but you will have an opportunity to then revisit the slides of the webinar and the entire webinar that we are recording for you and will be eventually available on our YouTube channel. Today with me, I have Christine Thelker, who is the dementia advocate and a member of Dementia Alliance International from Canada, Dr. Stephen Connor, who is the Executive Director of Worldwide Hospice Palliative Care Alliance, WHPCA, Justin Derbyshire, who is the Chief Executive Officer of HelpAge International, Dr. Zipporah Ali, the Executive Director of the Kenya Hospices Palliative Care Association, and also a board member of WHPCA and of ADOK, ADI owns member in Kenya. Next slide, please. We also have Pao Pheng, who is a caregiver and will speak from Indonesia, Dr. Liz Sampson, who is the Principal Investigator of EMBED, Empowering Better End-of-Life Dementia Care from UCL London, and Dr. Adam Gordon, a Vice President of Academic Affairs for the British Geriatrics Society, and professor at the University of Nottingham. After the speakers have spoken, each will have 5 minutes, we will have a poll, and then finally will be followed by a question and answer session. Now, if you have questions throughout the webinar, please write them in the Q&A box. If you want to just have a chat and say to everybody who you are, you're very welcome to do that in the chat box. So the Q&A box for question and answer that we'll answer at the end, the chat box for just greeting and salutations. We will aim to answer all questions. If we run out of time, we will then send the questions to the speakers to answer individually. Thank you so much. Now, next slide, please, Annie. So at the end, as I said, we are going to have a Mentimeter. We're going to have a poll, and the poll is going to give us a sense of what are the words that best describe your feelings as participants to this webinar. You know that we always try to do our webinars as interactive exercises. And your feelings specifically regarding the topics of this webinar, which is of course palliative care and dementia. You will be able to answer 2 pre-selected answers, is a kind of multiple choice. And if you want to go and have a look at the website that we will ask you to log in to do that at the end of the webinar, you can do it now. Is at the website that you can see on the slide, https://www.menti.com. Okay, so now next slide, please. I am delighted to give the floor to Christine Thelker. Christine Thelker is a dementia advocate from Vernon, British Columbia. I should say to you today that we have people from a variety of time zones, ranging from Vancouver to Jakarta. Christine describes herself as bright, fun, and adventurer. She, at 59, she says that her sense of humor has grown since her diagnosis. She was widowed at 47, and then she was diagnosed with vascular dementia and cerebrovascular disease at 56. Christine worked for Interior Health Authority for 13 years in various sites, and her most loved work was in dementia care and end-of-life care. She has also written a book. For this, I'm grateful, and she continues to advocate about the needs for a human rights approach to dementia. She is also part of Dementia Alliance International, which is an advocacy organization that partners with ADI. Her motto is, I am not done yet. Christine, the floor is yours.
Thank you, Paola. First off, I'd like to start by thanking ADI for the invitation to offer my reflections on this important topic and to congratulate you on hosting this event. Next slide, please. The topics I'm going to cover today are palliative care, advanced care directives, and the impact of the coronavirus pandemic. Next slide, please. For people with dementia, like myself, we've been facing serious discrimination in terms of being denied health care. We're definitely never offered palliative care until the very end stage, and this was and is the case long before COVID. You can see that DAI has been very proactive in terms of providing support for people with dementia during the pandemic, and this slide highlights our support. Because palliative care is based on individual needs, the services offered will differ. I have lived experience of palliative care for myself and members of my family, and past professional experience working on dementia units in long-term care in the nursing field. Since the COVID pandemic, many people have not been able to access palliative care and are therefore being denied adequate relief of pain and other symptoms of illness such as nausea, vomiting, and many others. Resources such as equipment needed to aid care at home, assistance for families to come together and talk about these sensitive issues, links to other services such as home help and financial support. Support for people to meet cultural obligations, support for emotional, social, and spiritual concerns, as well as counseling and grief support for them and their families is also missing. Many people, in fact, are dying alone. Next slide, please. We are facing even more stigma and isolation since the COVID pandemic, as are most older people. Palliative care helps people live their life as fully and as comfortably as possible when living with life-limiting or terminal illness. It identifies and treats symptoms which may be physical, emotional, spiritual, or social. As Kate Swaffer says, people without dementia are not used to enforced isolation or social and physical distancing, while people with dementia experience it from the day we dare to share our diagnosis. Isolation, stigma, discrimination, and distancing, social and physical, are the daily realities of most people living with dementia. We are all facing increased difficulties due to limited access, not only to equipment in home support, equipment including PPEs, and health care, including palliative care. More people over 80 have died from COVID without access to palliative care and without the support of their families due to the restrictions imposed upon healthcare systems and society in general. COVID-19 has highlighted that a great many people are experiencing personal signs of distress. This is a normal human response to the pandemic, but one which has highlighted that people with dementia are having normal human responses or signs of distress due to changes forced on them by dementia rather than BPSD. And related to palliative care is advanced care planning, which is more important than ever in these uncertain times. In the months ahead, thousands of people will face the prospect of becoming suddenly and seriously unwell. Distressingly, they will probably have to face being denied health care. I'm concerned that many people do not have advanced care directives, mainly because they don't understand that just because we tell people what we want does not mean that will happen if it's not in legal documents. And many people over 65 are indeed without an advanced care directive, which creates serious and problematic issues as we face the impact of the COVID pandemic. An advanced care directive is important as nearly 50% of people who become ill will not be able to make their own end-of-life medical decisions at this very difficult time in history. And although it may make no difference at this point, as the elderly and infirmed, including people with dementia, are being denied medical care. This is an all too real and sad, sobering thought. Again, this highlights yet another area we have failed our most vulnerable. Next slide, please. In closing, I want to remind you of my quote that clearly states how I personally feel. I am more frightened by the thought of ending up in any type of care than I ever have been of my dementia itself. Thank you for allowing me to share my thoughts.
Thank you, Chrissy. I cannot thank you enough, first of all, for being up at an ungodly hour of the morning, 4 a.m., to give us that very important testimony about what it means to be a person with dementia at this moment in time, knowing how difficult it is to access palliative care, and giving us also a sense of the scale of the problem that we are facing. Now, without further ado, I would like to move on to Stephen Connor. I can see that we have over 28 nations online, quite a lot of people already in the Q&A and the chat. Somebody wants to have the link to the webinar, and the team will try and provide that. But I'm going to give the floor to Stephen Connor now. Dr. Connor is the Executive Director of the UK charity Worldwide Hospice Palliative Care Alliance. He joins us today from the East Coast in the US. WHPCA is the global alliance of 250 national and regional hospices and palliative care organizations in 92 countries, and it's in official relation with WHO. The WHPCA advocates, communicates, and helps develop palliative care worldwide with a focus on low and middle income countries. And Dr. Connor has worked in palliative care continuously for the past 41 years in various roles. When I met Stephen a few years back in Geneva, I was in a complex personal situation regarding palliative care. I've had experience myself personally as a carer, and I know full well how important it is for anyone out there that has a condition or is caring for someone for a condition to know that in the chaos that happens in the last moments of life of an individual, to have the comfort of some orderly thought around what is going to happen is incredibly comforting. And it was great at the time to meet Stephen and some of his colleagues who were so knowledgeable about palliative care, and I always promised myself that whatever I could do to help make life easier for people that didn't have access to it, I would try to do. So it's a great pleasure for me to introduce Stephen Connor. Stephen, the floor is yours.
Thank you very much, Paola. And Christine, thank you as well for a really great description of what palliative care means. It's so important that we have the voices of people with lived experience, and that should guide everything we do in terms of response to the need for palliative care for people living with dementia. Next slide, please. We've just Saturday published the second edition of the Global Atlas of Palliative Care, and I wanted to just give just a kind of a broad picture of palliative care globally. This is an advocacy tool done in participation with the World Health Organization to help us advocate for, but also monitor progress or lack thereof in palliative care development. Next slide. So we have over 1 million people die every week on our planet. We have a need for palliative care presently that is almost 57 million people, including almost 26 million at or near the end of life. Most of those people live in low and middle income countries, over 3/4. Most are older, but also we have children who need palliative care, about 7%. In only about 15% of countries do we have good integration into the healthcare systems that exist. Almost 70%, almost 69%. It's very sketchy and sometimes hard to receive palliative care. And whenever we care for anybody with a palliative care need, it's not just the person living with the disease, but their family who's living with the disease as well. Next slide. As best we can tell, only about 7 million of those almost 57 million are receiving palliative care from about 25,000 providers of services. It's really important that we try to integrate palliative care into existing healthcare systems, and every healthcare professional who graduates from medical school, nursing college, or even in mental health training has at least a basic understanding of palliative care. Right now, we have huge problems for people living with dementia, but also for many other illnesses. Next slide. We have, actually, dementia is actually the 4th biggest diagnostic category for palliative care. Most people didn't even realize that people with dementia should get palliative care, as little as a few years ago. And now we know that it's just especially an important group, diagnostic group, and group of part of humanity. Cancer, of course, right now is still the #1 reason, but also for HIV, for cardiovascular diseases and heart failure. But dementia is really a significant amount of the need. Next slide, please. So we have estimated in the Atlas that about 6.5 million people at present are in need of palliative care. That's mostly 4 million of those in low and middle income countries, 2.5 million in high income countries. Most of those actually are prior to the end of life. So about 2 million out of the 6.5 are patients approaching the end of life. But as it was mentioned, palliative care and the skills of palliative care need to come into play from the diagnosis forward. So we have a large number of people prior to end of life. We also know that we're going to see a huge increase in the need for palliative care for dementia. We have there's a projection done by a colleague of hers, Professor Sleeman, who is projecting a 264% increase between 2016 and 2060 in the number of people with dementia needing palliative care. And COVID adds many complications to this picture. We have an increased need. We even before COVID, we had needs for caregiver support and respite and help with grief issues, but that is just compounded by the pandemic. There is great risk of infection for anyone with a life-limiting illness or serious health-related suffering. And we have had a problem with people not aggressively or appropriately managing symptoms. Next slide. And finally, we'll talk more about this at the end, but we really have we need to do a lot more advocacy together as both long-term care advocates, dementia advocates for the aged, for people or older people, because we need to ensure that people have equitable access to palliative care. Palliative care is in general a human right, and that's true for people with dementia. We have to all come together to increase the political will needed to make these changes, and we have to monitor the situation carefully. I'm going to try to stick to time, so I'm going to close there and thank everyone for your kind attention.
Thank you so much, Stephen. This has been such an important presentation full of facts and figures that are going to inform our discussion. And no doubt there will be a discussion. There's already a lot in the Q&A. I'll be fast in my introduction of the next speaker, though, as we don't want to run out of time. Next speaker is Justin Derbyshire, who is the CEO of HelpAge International. HelpAge International facilitates older people to claim their rights, challenge discrimination, and overcome poverty, such that they can lead dignified, secure, active, and healthy lives. Justin has been a long time with HelpAge and has been very active at global and international advocacy level, especially at the UN and WHO. I have to say, for us at ADI, whenever we hear or read something done by HelpAge International, it always warms our heart, because we think, someone else that speaks our language really understands what we do. It's such a joy to work with HelpAge International. So Justin, it's a pleasure to have you here. The floor is yours.
Paola, thank you very much. And thank you to you and everybody at ADI for developing this webinar and bringing further awareness to this critical issue. If we could go to the first slide, please. It is obviously very much apparent from early on in the pandemic that older people were at particularly high risk from the health impacts of COVID-19. You will all know from the information that you've seen on a daily basis how the data has shown across Europe in particular that the amount of deaths for people over 60, and how we've seen over 80% of those in ICUs and admission were people over ages of 50 to 79. If you could go to the next slide. Information from across countries shows the majority of deaths occur to people in older age. We also know that recent figures from England and Wales has shown that 1 in people who have died from COVID-19 have had dementia. As many of you are aware, the prevalence of dementia in older people is estimated to be between 5 and 8% globally. Specific data from this pandemic in lower and middle income countries has been difficult to access. We've had to rely on HelpAge's rapid needs assessment and anecdotal information from our network members and partners who've shared experiences of the challenges older people are facing, and that older people with dementia have been heavily impacted due to the low levels of understanding of dementia, the lack of health services, the lack of palliative care available, and the high levels of stigma and discrimination that are being exacerbated by the pandemic. If you could go to the next slide. Early data has also showed that the risks to underlying health conditions, again, you will have seen that across Europe, 96% who've died from COVID have had at least one underlying health condition. The rapid needs assessment that HelpAge have conducted has shown that of older people in 14 countries, 70% reported at least one underlying health condition. The types of conditions being shown to increase a risk of COVID-19 are more likely to affect older people. The complexities of health in old age, rates of multimorbidity, prevalence of chronic and life-limiting illnesses means older people are most likely to need palliative care, access which has been affected from the pandemic. We know from the report that Stephen mentioned that 40% of patients in need of palliative care are age 70 or older. Older people have been struggling to access this, particularly in lower and middle income countries. Palliative care is often not sufficiently included in long-term care support services and systems. When older people are cared for, they're cared for at home, and their access to support has been hugely restricted throughout the last 6 months. If you could go to the next slide. HelpAge's rapid needs assessment have looked at older people's access to healthcare facilities and testing for treatment, and more generally, the access to health facilities during this pandemic. 50% of older people surveyed have not been able to access or know where to go to for COVID testing and treatment, and 11% saying that the nearest facility was between 1 and 3 hours from their home. HelpAge's data has also shown that the immediate impacts of COVID-19 on their broader health and well-being, with 32% unable to access their medication. If you could go to the next slide. HelpAge's data has shown also that the fear and anxiety among older people, most of all creating huge worrying rates of depression. 41% saying they feel depressed. 17% feel they're not able to cope with the current situation. It is having an impact on older people's mental health for a number of reasons. It is having an impact on their current conditions through increase of levels of loneliness and isolation. This is particularly pronounced by those who are already feeling isolated, those with dementia, and those who depend on others for care and support. In March, my mother was suffering from hallucinations once or twice a month. Lockdown followed, and no social interaction, no time off for my stepfather, no visits to the doctor, no community groups, and no options for care. By June, her hallucinations were up twice a week, and now they are daily. Her illness was developing, and it was spreading, but it's clearly been accelerated due to the last 6 months. My mother still benefits from online care. My stepfather received training pre and post lockdown. They live in a developed country, and they are fortunate to have the support they do. Millions of older people around the world don't even have a name for the disease. They are not counted. They cannot access palliative care. It's essential that we make change now. It is needed. We need to work together to ensure that we have the data we need, that we have access to long-term care and support systems, and that there is, as Stephen said, equitable access to health services and palliative care. Thank you very much.
Thank you very much, Justin, for this wonderful presentation, your personal story, also for sharing it with us about your mother, a situation that is reflected in so many people that we're speaking with. Can I remind all that are listening to us to read the incredible blog of Hilary Doxford, who lives with dementia, that wrote about what kind of havoc social isolation is putting people with dementia through. And I also would like to draw your attention to the incredible figures that Justin has shared with us about old age and COVID-19 and the mortality rate, and remind all of you that we have and continue to ask the WHO for figures specifically for dementia, which are sorely lacking. Only the UK, Canada and Italy have so far published the figures, which are ghastly. And we do need to understand more what is happening out there. And so I'll also ask Stephen and Justin to join us in trying to understand a little bit more and ask for more action from governments. But all of us can play our part. All of you, there are 30 countries online, can ask your governments for more information about this topic. Now, it is a great pleasure to introduce our next speaker, who is Dr. Zipporah Ali, who is the Executive Director of the Kenya Hospices Palliative Care Association. She is also a board member of WHPCA, the organization of Stephen, and she's also a board member of Alzheimer's and Dementia Organization Kenya, ADOK, which is the partner of ADI, the member of ADI for Kenya. So it's a joy to have us with us, and you can tell us more about the situation in Africa. I have incidentally noticed that we have plenty of African countries online today, Dr. Ali, so you are speaking to a very engaged audience. Thank you so much. The floor is yours. And you may need to unmute yourself.
Well, good afternoon, everyone. I want to say thank you to Paola for inviting me onto this webinar, and I also want to say thank you to the previous speakers for sharing what you're doing. Thank you, Stephen, for at least telling people about the new Atlas for Palliative Care and for sharing the statistics. I won't be sharing any statistics because I knew Stephen would address those ones. I'll really be sharing about the challenges we might be having in Africa. Can I have the next slide, please? I think maybe some of you have seen this article, which talks about the challenges that have been identified by some of the studies in the Western countries. And basically, some of the things that Stephen talked about, lack of access to palliative care, is one of the biggest things we really have in Africa and developing countries, specifically, not just for older persons, but generally for all across all ages. But of course, more specifically for older persons, because one, people who are old are expected not to, to die and not necessarily to access healthcare services. Healthcare services are supposed to focus on the younger generation. So there's that misconception that really makes it very difficult for older persons to access services. Even having older persons friendly services is a big problem in our countries. And one of the other things also is, of course, access to symptom management and also pain relief. Somebody with arthritis is supposed to live with arthritis if they're old, because that is part of life. So there are all these things that are not being done for this group of people that are not right, are against human rights: access to palliative care, access to pain management, access to spiritual and spiritual care, psychosocial care, access to even being able to decide where they want to die. And we have seen some of these challenges specifically with COVID-19, people who are sick, and maybe we have the older generation getting COVID-19, and if they're going to hospitals, they might have to end up dying in the ICU in the hospital. So they would rather die at home, but they're not giving that preference. So we have all these challenges that might be facing the Western culture, but also some challenges that we see in our developing countries. Next slide, please. Next slide, please. So in Africa, and specifically in my own country, and quite a number of our neighboring countries, older people with dementia really go through a lot, and their families as well. These are some of the newspaper articles. Maybe you have read on news, maybe you have heard on BBC or any area else about people being burnt because they are witches. Most of these people are not witches. And if they're witches, they shouldn't still be burned. That's not really right. Most of these people are old persons with dementia. They are not able, because they are behaving in a way that the public does not understand, they are labeled as witches. So you'll find, especially women are taken out, they are lynched by the public, by the community, they are burnt to death, they are stoned to death, they're tied up, they're ostracized from their community, they're locked up in houses simply because they have got an illness that nobody's understanding. So we really have a big problem because we need to educate our public to understand what dementia is, that it's an illness, that these people need our support and not for us to stigmatize and punish them. We have even healthcare providers. As healthcare providers, we don't really understand how to deal with older persons. We are not able to make a good diagnosis of dementia. We're not able to make a, to come up with a treatment plan. So we need to really work on awareness, creating awareness in our own public, in our own government, among our policymakers, to understand what palliative care is and to come up with work plans and plans and strategies and policies on how you can deal with dementia and other problems that older people might be having. So we have a lot to do as developing countries. First, we need to do a lot of advocacy, awareness, and we need to integrate training in our healthcare training. We need to integrate palliative care and just generally care for the older persons in our undergraduate and postgraduate trainings. We like that kind of system. So we don't have any budgets allocated to older persons specifically. We don't have even, a support system for those who don't have families to take care of them, to be put in somewhere they can be taken care of. We do not have even home for the older persons like you do maybe in the Western culture, but also this might not be culturally appropriate for us, but we don't have strong systems that can support people who need palliative care when they have many other issues as well, comorbidities, other existing diseases. So next slide, please. And one of the things also I need to mention is we don't have enough support groups for people living with dementia or older persons. So you find a few groups here and there that are struggling. Most of these groups are mainly groups that were formed because somebody had a mother, a father, or a relative who had dementia, and they come together to support people with dementias. So to address some of these issues in Kenya, we have a project, an ongoing project that has got several partners. I've put down the partners on the slide: Strengthening Response to Dementia in Developing Countries, that is STRIDE, African Mental Health Research and Training, Alzheimer Dementia Organization of Kenya, Ministry of Health is involved, the University of Nairobi, Globe and GFRC, and my organization that I work for, Kenya Hospice and Political Association. We are looking at how can we come up with plans for helping people with dementia. And we've looked at quite a number of factors. We've looked at socioeconomic factors, health systems factors. We've looked at we've looked at cultural factors. We've looked at different factors and how we can address these factors. So we've actually come up with quite a number of things that we're addressing. We are hoping that whatever you're going to address is eventually going to make it possible for people with dementia to access care, not just palliative care, but to access care across the continuum of their disease. We're also looking at how we can create awareness to the public, policymakers, and everybody else, but also looking at how we can educate people on maybe minimizing the risk of getting dementia. Next slide, please. Next slide. I'm almost finishing. So we have to change the mindset of our people because that's where it starts. If we don't have the public understanding what dementia is, we'll still continue having people burned, stoned to death. We need to change the mindset of the people. We need to educate the healthcare workers. We need to have policies and plans that are specific for older persons with dementia. And also we need to integrate palliative care into the healthcare for these people. But we're also advocating that their care should be put under our National Health Insurance Fund and also our UHC program. So there is a lot that we still need to do as developing countries. And I think these issues actually cut across all the African countries. We are facing the same challenges throughout. Thank you.
Thank you very much, Dr. Ali. This has been a really important testimony. There is just so much work to do. You have also raised the important issue of the National Plan for Dementia. I think, you know, as everything in life, one of the important things is to recognize that there is a problem. And I think from that point of view, Kenya is understanding more and more what the issues are. Your group and the groups that you're working with are doing a giant review really of the situation and bringing to the attention of the government what has happened and how best to bring the discourse forward. We harbor very strong hopes to see the first dementia plan in Africa come from Kenya. And we will continue to support you guys as much as we possibly can. Now I'm going to move on, but there are some brilliant questions in the Q&A, so we're going to come back to them. And I'm going to introduce you to Pao Pheng, who is a caregiver coming from Jakarta in Indonesia. Now, Pao Pheng is a housewife and she lives with her husband Handikin, elder daughter and younger son. Pao has been a caregiver to her mother, who is diagnosed with Alzheimer since 2019. Her mother is in late stage, and she has also been providing palliative care in the past year. She was also a full-time caregiver to her father, who had paralysis for about 15 years until he passed away in 2016. In 2019, Pao and Handikin ran a fundraising campaign on the Everest for ALSI, which managed to raise more than $10,000 to support Alzheimer's Indonesia vision and mission. Pao keeps herself busy by being involved in women empowerment community, managing her social media account, focusing on self-development, and recently volunteering in various Alzheimer's Indonesia events. It's a pleasure to have us with us, Pao. Thank you for being with us at 7 p.m. at night in Jakarta. The floor is yours.
Okay, hi, thank you, Paola. Good morning, good afternoon, good evening, ladies and gentlemen. It's an honor for me to be here with you all. My name is Pao Pheng and people call me Pao. I'm a caregiver and I live in Jakarta, Indonesia. Today, I would like to share about my journey as a caregiver for my parents who are diagnosed from dementia at palliative stage. Next slide, please. My caregiver journey started 20 years ago. That time I took care of my father who passed away in 2016. He suffered from a number of diseases and dementia is one of them. And now I'm a caregiver for my mother. She was diagnosed with dementia just last year. Yet actually, she started showing the symptoms since years ago, but none of us realized it. When I first heard the news about my mother, I was shocked and frustrated. I felt hopeless and also lonely. I didn't think that I would be strong enough to go over the situation like it was with my father. Then I realized that complaining will not solve anything. It won't change anything. I learned to accept all of this and change my mindset. This is not a punishment, yet for me it's a blessing to be able to take care of my mother while I can. It's not an easy to be a caregiver alone. I let my family and close friend knows about my mother's condition. The changes we saw in her were not because she did them on purpose. Instead, it was because of her degrading cognitive abilities. I reached out to my core family members and shared tasks to provide the best care for our mother. I focused on spending time with her, like reading a book for her, combing her hair, and showing the old photo albums of our family, and just talk about it. Then I came to know about ALSI. ALSI has been very helpful to provide insights and knowledge about dementia and how to deal with it. I wish I knew ALSI way sooner. Last but not least, I have to take care of myself too. I told myself, hey, it is okay to not be okay. It took a courage for me to admit that I'm not okay sometimes. And I also need help as a caregiver. Because taking care of people with dementia at palliative stage will take a heavy toll to the caregivers. I often face dilemma to split time between my mother, my own family, and even for myself. Then having talked to ALSI and learned from other caregivers, I decided to take action to allow myself live a quality life. I've been making time to take morning walks and joining sportive communities. I learned new things that spark joy to myself, especially during this pandemic time, such as planting and baking. Next slide, please. The challenging journey as a caregiver brings me to do things beyond my imagination. In 2019, my husband and I initiated a fundraising campaign for ALSI while hiking to the Everest Base Camp. It was surely one life-changing experience for both of us. Next slide, please. It does not stop there. There is a stronger calling in me to continue supporting ALZI in spreading early awareness about dementia and strengthening other caregivers in this journey. I got the opportunity to share my caregiving and fundraising stories in a number of seminars and also webinars. I feel blessed and find that this gives my life a bigger purpose. And the next slide, please. Well, thank you everyone for your kind attention. I would like to close my story with this line. We cannot stop the rain from pouring, but we can dance in it gracefully. Dementia is not just all about doom and gloom, but we can always choose to live with it in joyful and meaningful ways. Thank you, everyone.
Thank you very much, Pao, for giving us this wonderful testimony. I think these words, we cannot stop the rain falling, but we can dance gracefully in it, is also so very Indonesian. And I have seen so much graceful dancing as a way to overcome the doom and gloom that sometimes some of our conditions take. Your positivity is wonderful, and I'm sure you've inspired many, many people. Can I please remind everybody that if you have questions for our panelists, you can use the Q&A. There is quite a few questions already there. And if you want to greet everybody, you can use the chat line. We will come back to this fantastic testimony of Pao. And now I am not going to stop. I'm going to go on to our next speaker, who is Dr. Liz Sampson, who is the Principal Investigator of EMBED, Empowering Better End-of-Life Dementia Care at UCL in London. Her work focuses on key issues for people with dementia who are reaching the end of their lives, epidemiology and health services research on dementia and delirium in acute hospitals, and better understanding and management of common symptoms. Now, Liz, the floor is yours. We're looking forward to have your perspective on this issue. Thank you.
Thank you very much, and thank you for asking me to speak on this amazing worldwide seminar today. So if I could have my first slide, please. So I'm going to talk to you about palliative care and dementia in the context of the Empowering Better End of Life Dementia Care Programme. This is a large multi-component programme grant funded by the National Institute of Health Research and Economic and Social Research Council in the UK. It's the largest grant that's been given in the UK for palliative care and dementia, and it's a large collaboration between University College London, King's College, and many in the charity and the third sector. And the overall aim of EMBED Care is to use this funding to develop knowledge and in a variety of ways through large data, cohort studies, co-design, and find new ways in the UK to improve end-of-life care for people with dementia. So I'm the Principal Investigator for the grant, and it's co-led by Dr. Catherine Evans at King's College. So next slide, please. So often we ask, what is palliative care? And on the left-hand side, you have the definition as given by the World Health Organization. And then you also see this quite deceptively simple diagram developed by the European Association of Palliative Care. So one of the first strands of the EMBED Care programme will be to look at the interface between dementia care and palliative care. We know that people with dementia, relatives, carers, even staff, don't actually notice or mind who provides the dementia palliative care. It could be a geriatrician, it could be primary care where most dementia palliative care is given, or an old age psychiatrist. So the first part of our programme, which started about 18 months ago, was to look at the overlap in the interface to get a really clear definition of dementia palliative care that spans specialities and looks at the key components that need to be given. Next slide, please. So one of the things that's also come to light during our programme grant is COVID, and we've been mindful of this, and we've included COVID questions and a study looking at end-of-life care needs in people with dementia and COVID. So you can see from this data on the left that in a hospital cohort of 100 people who died with COVID, over a third of these people in an acute hospital in South London actually had dementia. And the common symptoms were breathlessness. And one of the key pillars of EMBED care is to look at how we maximise comfort and quality of life, and we take a needs-based approach to symptoms. So we don't think about prognosis. Our underpinning philosophy is that this palliative care approach is about meeting needs. And one of the main unmet needs in people reaching the end of life with dementia is the assessment of pain and physical symptoms. And the other key role from the perspective of the philosophy of our programme is that we have to manage distress and contain uncertainty. And what I mean by that as a clinician who also works in the acute hospital with people reaching the end of life with dementia is that we say it's okay not to know how long your progress is or what's going to happen over the next 48 hours. We will manage your symptoms as best as we can. Next slide, please. The other really important strand of the whole EMBED care programme, which is in total a 5-year programme, is to look at the needs of families, friends and staff. Because we know that's a neglected area of dementia palliative care research. Other groups that we're looking at in the programme are people with young onset dementias and also people with rapidly progressive dementias. So as we characterise the symptoms and the needs of the people with those illnesses, we're also going to be looking much more at the needs of carers. And I think this quote from Cicely Saunders is important, especially during COVID times, which is how people die, remain in the memory of those who live on. And we know that during COVID, we're likely to see much more anticipatory grief, which is grief before the person with dementia has died, and much more complicated grief after the bereavement because of prolonged periods without visiting. We also know from previous studies that when people with dementia receive very aggressive, inappropriate medical care, the grief experience of the carers is worse. So it has knock-on effects for that. And also during COVID, people can't grieve within the normal religious cultural norms. And also this issue, which is really important, which we haven't really acknowledged, is how staff grieve for people as well. So when a person with dementia dies in a care home or on a hospital ward, the staff will go through a grieving process too. And this is something we're going to be looking at in our programme over the next few years. Next slide, please. So thinking about how we get it right and some practical tools. Because of COVID, we were able to obtain some extra money and we've been able to think about conversations, and this has come up in the chat and some of the other questions. So some of our project team, Dr. Nurea Kapali and Nathan Davis, obtained rapid response COVID funding to develop a decision support tool for people with dementia and their family carers. This is different to advanced care planning. This is a specific decision support tool about making decisions about whether you would want to go to hospital and what sort of care you would want to receive in COVID or due to any other acute medical condition. It allows carers and people with dementia to prioritise and clarify their views and their values. It's a simple document that's been developed in co-design with practitioners, people with dementia and carers, and it's evidence-based. And we were delighted that this has now been adopted by the UK National Health Service as a decision aid and will be very helpful, we hope, during the second wave, and that's available online. Another part of our programme pertinent to COVID is the assessment of symptoms, and the IPOS-DEM is a symptom scale which allows clinicians, non-clinicians, carers to assess the overall symptom burden for the person with dementia and then use that to talk to other professionals and get the help that's needed. That's available online and includes a holistic symptom assessment framework that can be used in any setting. And we've also done some work in the programme around dementia-friendly communities, and we have a PhD student specifically looking at how dementia-friendly communities and compassionate communities can support end of life in dementia as well. So final slide, please. So I've finished. Hopefully I'm to time. I think I just want to highlight that please contact me with my email address. We have a large mailing list and regular newsletters about the programme. It's impossible to encapsulate the work in a 5-minute talk. We're grateful to the support of Alzheimer's Society, Stephen at the World Hospice and Palliative Care Association as well, and numerous other organisations. and we hope to spend our money very well over the next few years. Thank you.
Thank you ever so much, Liz, for this very interesting and insightful presentation. There were a couple of points, how your program focuses on meeting needs, no matter what the prognosis is, which is so important. And I'm sure that Pao and Chrissy would be also very interested to hear about that particular approach. I also was delighted to see how you have developed the decision support tool. As you, I'm sure, know, we presented a position paper very early on during COVID with your wonderful colleague, Jade Livingstone from UCL, drawing attention globally to this problem that going to hospital may not be the best thing for people to do if they had COVID and dementia, based on the evidence that was coming out from Italy, Spain, etc., brought together to us by the excellent LTC COVID facility that has been working so hard during COVID to gather data and evidence. Now, there are more and more questions in the box, but let's pass to our last but not least speakers, Professor Adam Gordon, who is a professor of care of the older people at the University of Nottingham. He's also the Vice President of Academic Affairs at the British Geriatrics Society. He has a research interest in how care is delivered in care homes and has been active in supporting care home staff and managers during the pandemic, including through the innovative use of a WhatsApp online peer support community of practice. He has also run a COVID ward for older people between March and July, so it brings us first-hand clinical experience of what has been happening. Dr. Gordon, your testimony is terribly precious for us, and we welcome you to the webinar. The floor is yours.
Thank you. I was just trying to work out what I could possibly add after all the eminent and illustrious speakers that we've had so far. And what I wanted to do was to provide some perspectives from having worked with staff, managers and residents of UK care homes through the pandemic. Care homes are in some other parts of the world called nursing homes. They are places which provide 24-hour care for older people as they start to approach the end of life. In UK care homes, at least between 70 and 80% of the residents will have dementia. So the insights from the care home sector are very relevant to those of us that care a great deal about how care is delivered to people with dementia. If you are working in the care home sector at the moment, if you live in it, or if you have relatives that live in it, often the only way that you can make sense of the current situation is through newspaper headlines. And the newspaper headlines have been very shrill, they have been very angry at times, and they've often presented a very simplistic view of what's happening in the care home sector. And what I want to just put to you over the next 3 or 4 minutes is that where there are simple but conflicting views in the media, it usually means that not enough time or thought or resource has been invested in making the situation better. And I want to just give you 2 examples from the UK care home sector at the moment. Next slide, please. This is a newspaper article just from last week from the Guardian newspaper, which talks about the harm that comes to older people with dementia living in care homes if they are isolated and cannot have access to visitors. There is no doubt that this is very harmful for people, both in terms of the physical deterioration that occurs if you cannot move out of your bedroom, but also in terms of the cognitive deterioration that occurs if you cannot see people that you know and love. And the newspapers have been getting very exercised about this and claiming that it is a travesty. Next slide, please. There is, of course, an alternative argument, which is another travesty that has taken place during the pandemic, is that we have not sufficiently protected older people who live in care homes, and we haven't isolated them well enough. We know that in the first half of this year, the death rate in care homes in our country, in the United Kingdom, and this was mirrored around the world, approximately doubled. And we have good evidence now that the main way in which infection came into care homes was by staff or visiting professionals coming in to care homes. And in both there are very clear rationales for both sides of this argument, and it can be very confusing if you're a relative trying to make sense of what the right thing to do is and what to expect. And the answer is, of course, that you can have both things. You can protect people in a care home setting, and you can also ensure that relatives or care partners are able to get in and provide support in such a way that they do not introduce infection and harm residents. Next slide, please. And the answer is, of course, that the way to do this is to invest sufficiently in testing, not just for care home residents and staff, but for people that visit care homes. And one of the real challenges in our country, at least, has been that people who live in care homes and who provide support to those living in care homes have not had sufficient or sufficiently timely access to testing. Next slide, please. There are, of course, possibly solutions. And one example from pilot studies which are taking place around the United Kingdom at the moment is the idea of point of care testing, where relatives can be tested when they arrive at the care home setting and get the results within just over an hour. Of course, if the government are to want for this to happen, they will have to invest in this technology, and it will be our job as people that advocate for the people with dementia that live in the long-term care sector to make the case for this. Next slide, please. Another issue which, well, I just realized this is animated, so if we could just click through it, please. Stop there. Thank you. Another dilemma which has been presented as a sort of choice, certainly in the United Kingdom, but I've also heard from colleagues in the US and Canada that it's been presented in similar ways there, is that you can either go to hospital if you want active care for COVID, or you can stay in your care facility and receive end-of-life care only. And this is becoming increasingly clear as a false dichotomy, and we need to look at how we provide more care in care homes, and also how we provide more palliative care in hospitals, so that people can separate out the decision about where they want to receive care and the type of care that they receive. And we now have good examples from around the UK and from around the globe of quite advanced care being provided in care home settings, so that people can really make more nuanced choices about what they want if they get COVID or other life-threatening conditions during the pandemic. Next slide, please. Next slide, please. One of the real kind of issues that has become clear during the pandemic is that it's very difficult for care home staff and residents and relatives to make decisions without appropriate support. And one of the real challenges during the pandemic has been the extent to which healthcare support has withdrawn from the care home sector in order to shelter or shield care home residents. We've known for a while that we as geriatricians call it comprehensive geriatric assessment, but Liz as a palliative care physician would call this good holistic care. But we know for a fact that to provide good care to people with complex conditions, we need multidisciplinary teams that work with care home staff, that work with care home residents, that work with families to really conduct detailed assessments and put in place advanced and complex care plans that meet individual preferences and choices. And if the COVID pandemic has taught us anything, it's the need to invest more time, resource and effort in this in the future. So what I wanted to say is that the media has presented this as a series of simple dilemmas and tensions which have defined the life of people with dementia living in care homes during the pandemic. In reality, it's more complicated than this, and it's up to those of us that advocate for people with dementia living in long-term care to make the case for more time, thought and money to be invested in presenting more nuanced choices to people with dementia. Thank you.
Dr. Gordon, I really cannot thank you enough. I think everybody on this webinar will agree that the way, the breadth of presentation by all the panelists has been extraordinary. All of you have tackled different angles and reminding us of the simplicity with which some of the public is facing some of these incredibly nuanced dilemma, and the way that they can be used as very blunt instruments, these statements, when actually there is a very, very complex situation underneath, but of course it's also very difficult to explain. It reminds us also of the importance for us working in civil society about making complicated things easy to understand, not an easy task, but one that certainly many of those on this panel also have to grapple every day. So thank you very much for this very important contribution. Now we have a lot of questions coming in. Can I remind everybody that wants to ask a question, please ask it in the Q&A box. I will pick probably a couple. I don't think we'll have time to answer more than that. But in the meantime, we are going to pass now to a poll. We are going to have a poll. And as I told you at the beginning, we are going to ask you to use this poll on www.menti.com at the link that you see. So please log on to the link. You are going to be asked to put a code, or you can simply use your QR scanner. Now everybody is much more familiar with QR scanners to access this poll, and it will generate a word cloud. You should think about what word best describes your feelings after this webinar regarding palliative care and dementia care. You are allowed to use 2 different words. This will give us a snapshot feeling about what are the senses that are coming out of this specific webinar. In the meantime, whilst you do that, we'll leave you 2 or 3 minutes to do that. I will decide which question to pick up first. I have to say there is a fantastic amount of questions. Some of them are specifically directed to one of our speakers. Some can be answered to by more of you. So another couple of minutes for you to do the poll. Okay, the first results are coming out. There is essential, yes, so true. Hope and hopeful, so nice to see that. But essential continues to have a lot. And essential really gives us a direction of travel about our work. We do need to continue to advocate for palliative care, make it more something that people understand at all levels. Last year, I spent some time at the Vatican with the Wish Foundation in Qatar discussing religious issues around palliative and end of life. And it was wonderful to see how much understanding there was and support. There is a lot of ignorance in the world. A lot of people don't think that these issues are important, but actually they are. And there is a lot of willingness to make them more mainstream. That's what we need to do. I think all the speakers today have pointed out to us. We will circulate this poll. Please continue voting whilst I pick up the first questions. And I think the first one I will pick up is from Natasha Fothergill-Misbah. The question is, palliative care has a focus on symptom management and needs. How can we address palliative care in context and cultures where focus is on cure or hope or recovery rather than the management of conditions? Does this have implications for palliative care training in order to equip doctors with necessary skills to deliver care effectively? Now, considering our speakers, can I ask, please, Dr. Our 2 last speakers, Dr. Sampson, to speak about it first. Could you please come online? Sorry, I've lost you a sec on the screen. Yes, thank you.
I think that's a really good question, and I think it also harks a little to what Adam was saying earlier, in that we can be very binary about things, and people think that palliative care means having no care or withdrawing care. So it's just about making decisions about, do not give this person oxygen, do not let them eat and drink. I think we, as people who work in palliative care field, I'm a liaison psychiatrist, this is my clinical background, so I work in acute hospitals. We have to give this message that palliative care does give hope. It's about maintaining and maximising quality of life, and about not necessarily stopping or withdrawing care. I think all of these binary decisions about, does someone go to hospital, don't they go to hospital, are actually not helping us with this debate. And I think that it's about really getting the message across to the public and also doctors in training that palliative care can actually be more care. It might involve a lot more care and more intervention, but it's about the right or the appropriate sort of intervention.
Thank you so much. Dr. Gordon, would you like to add a few words?
Yeah, so I would agree with Liz that the key message is that the two are not mutually exclusive, and you can provide some components of active care whilst also recognising a person with dementia and their families' wishes to have some components of palliative care as well. And I think that was the point I was trying to make at the end. In the UK, during the first wave of the pandemic, a lot of the focus was on venue of care, and the idea that if you wanted to have aggressive care, you went to a hospital, and if you wanted palliative care, you remained in a care home, and there was nothing in between. And in reality, what we're trying to do now is to get people to understand a more nuanced approach where you can have a bit of both or either, and it doesn't have to be a choice between end-of-life care and active care. And we should be enabling people, patients and their relatives to understand the choices in greater detail and greater nuance, and perhaps select in a much finer way from a variety of treatment options that are open to them.
Thank you so much. That really makes sense, considering the context of what we've been discussing. I'll move forward to the next question. I would like Justin and I would like Dr. Ali to answer this one. How do you think the societal reluctance to discuss death and dying among the general public, families and healthcare professionals in Kenya and perhaps wider Africa might impact on the uptake and delivery of palliative care? Accepting that the end is near is seen antithetical to care for many. Justin, would you like to start on a more global reply to that? And then Dr. Ali, perhaps you can focus on Kenya. Justin, I don't know if you're on mute.
I am fine. Thank you, Paola. Thank you for the question. I think in terms of what we need to do here is just a greater appreciation of the life cycle and understanding the positions that older people and those with different conditions are faced. And I feel that there's a lot of stigmatism and discrimination around different conditions as people are aging, and therefore is an importance in terms of awareness raising and sharing of information and working with communities and intergenerational focus on this to ensure all are aware of the different steps that people are going through, which will help not only support those with the condition now, but prepare others as they age.
Thank you very much. Dr. Ali, would you like to specifically answer this from Kenya? And
Thank you very much. I agree with what Justin has said. I think in Kenya, of course, yes, we do not see many people come. Well, we do have many palliative care services, but the number of patients who come are not as much as we'd expect because of the cultural dimensions around death and dying. And I think it's important, like has been said again by Justin, that we need to create, to do a lot of education and awareness on our public. I think the most important thing for me, what we have been doing in Kenya is trying to people to make understand why it's important to have palliative care integrated into their care, the benefits of palliative care, and focusing on quality of life, having a positive focus. And we might not mention the word death, but with time people will talk about their death. In Kenya, we might not talk about death, but once death has happened, we accept it, and we have all these cultural ways we mourn our loved ones. So I think it's just a matter of really educating people, trying to make death as a normal day-to-day conversation. And this is already happening with hospices and palliative care units. We have over 80 service providers in the country, across the country, and they're now introducing these topics of death and dying. We also usually want healthcare providers to think about their own death and dying first, so they can talk to patients about it, so that they know how to, what it is and what they can talk to the public about. So it's really about, I can't say changing culture because it's very difficult to change culture, but creating awareness and making it, something that we talk about in the news, in the media. We've actually have been addressing it in media. We talk about death. We have been talking about the 5 wishes in the last few years, just sensitizing people that what would you like to happen to you if you are to die. So that kind of a conversation kind of opens up, people to actually talk about what they would like to do if they are dying. So it brings in an aspect of talking about death and dying.
Thank you so much. Now I've got another 2 questions I would like to ask, so I can ask the speakers to keep their answer very brief. The next question is for Pao Pheng and for Chrissy Thelker. What are some of the key considerations when setting up appropriate environments for people with dementia? How can we make environment friendly to people living with dementia, especially in supporting palliative care? So could I have your reply, and you may want to unmute yourself. Pao, would you like to speak first? You will need to unmute yourself, Pao. Okay, Chrissy, if you are on the line, can you please speak first to this question?
Sure, thank you. Well, great presentations by everyone. So many things came to my mind through this. For me personally, living with dementia and having worked in the setting and still having my foot in that quite a bit, I always say to people, it doesn't matter what it takes, I'm not going there. And that's what I want to change. I shouldn't have to be living in fear of the fact of what's going to happen to me as I'm dying. And we do need, as Dr. Connor said earlier, that collaborative effort from all of our different groups and organizations in advocating for an across-the-board change in how we're addressing and educating everyone in regards to palliative care. Most people, general public, don't understand what palliative care is. They think it only pertains to the last few days of life. Most staff in care homes are not given the education around palliative care and end-of-life care so that they can better support the person and the families. And for me, that's critical. If somebody thinks I'm going to go into care, I want to know that my needs are understood by the people who are supposed to be caring for me. And right now that doesn't happen on the big scale. So I'm going to sort of tie that up, sort of leave it there. Those are sort of the most crucial pieces for me, and that is the education and changing how people view palliative and end-of-life care. We have to change that.
Thank you so much. That makes a lot of sense, and also answers to one of the last questions that was coming from Mexico on the same issue. So education is key. It's really, really important to raise awareness. There is a massive misunderstanding out there about what palliative care is and how could it be used or deployed, or even what could be done within certain cultures or religious environment. Actually, there is a lot more that can be communicated than people think. And we do need to all work together to make that happen. Pao, have you managed to unmute yourself? Would you like to comment on that?
Yes, Paola, could you repeat the question again? Sorry.
Yes, so what are some of the key considerations when setting up appropriate environment for people with dementia? I'm really sorry, but the chat line keeps popping in questions and covering my questions. How can we make environment friendly for people living with dementia, especially in supporting palliative care? So with your hat as a carer, how do you think the environment can be made more friendly in supporting palliative care?
Okay, thank you for the question. So based on my experience is, I think the most important is we as the young generation to give explanation to as much as people as around us about this dementia, because that is, I mean, the young generation has the power, has the energy to explain and give more awareness, because this is not just an issue for certain people or certain family. Like Christine just told us, a support system and knowledge and enough education. And also for me, it's like a good training. So it keep us, encourage us to give more awareness, to spread more information to many more people about this issue. And most important is, I mean, what we can do is from our family, because some of the people, like I know here, not only the caregiver, the people with dementia feel lonely. They feel nobody understand them. So I think it's really important to make the family, the core family itself, to make a comfort situation at home.
Thank you very much, Pao. That makes a lot of sense in the context of everything we have discussed. The last question I have, Stephen, this is difficult to answer in 1 minute, but I'm going to put it to you. What do you think should be done to improve palliative care in the UK? This is a specific question about one country, of which we clearly have a lot of listeners online. May I also give some tips to people that don't live in the UK? Stephen.
Yeah, I think we have to invest a lot more in home care for people with serious illness, including dementia. We have only about a quarter of people able to die at home in the UK, and most people are dying in hospitals. Sometimes they're shunted from care homes into the hospital, and are kind of, as we discussed earlier, disrupts continuity of care, creates false dichotomies and all that. But we really need, I mean, the system for home-based care in the UK is rather scattered. The hospices only care for about 6% of deaths. So you've got a palliative care, you've got a hospice system, which was, you know, maybe has been in the past called deluxe dying for the few. And you have a emerging palliative care service and groups like Marie Curie and others that do home care, but it's not integrated. It's not pulled together. I think a much better job could be done of helping people stay in their own, the place they call home.
Stephen, you've made a miracle there by replying in such a short time frame. I think many people will recognize that that is the issue also in their country. We have many listeners from Canada, from the US, for example, and I have heard from many that these are similar issues. Annie is now giving us again the wonderful word bubble and the key words: compassion, essential, hope and hopeful, misunderstood, and needed, dignity. So we will draw a lot of thoughts from that, and we hope to continue to work together. I cannot emphasize this enough. If we do not work together, we are not going to sort this out. And it's been such a joy to see also with us today people joining us from the International Hospice and Palliative Care Association. There was Catherine Peters with us from the World Patients Alliance and some other NGOs. We do need to work together. These NGOs may have not been on the webinar today with us, but they definitely were with us and have helped us frame this issue together. So we'll continue to work and advocate for palliative care. Thanks to all the speakers for being with me and to the hundreds of you that logged in today to listen to this conversation from over 32 countries. Thank you so much. Bye-bye.